So we have graduated to the third presentation. We talked about pneumology, we talked about basic heart images, and now we're going to talk about the lungs. So we're going to talk about thoracic ultrasound, really focusing on the lungs, okay? So when we talk about imaging the lungs, what I want to talk about, a brief introduction, talking about things that are superstar high yield for the boards, how do you identify a pneumothorax, talk about pleural effusions. Then I'll just kind of dabble a little bit about pulmonary embolism and pulmonary hypertension. These are not super high yield topics, but I wanted them to be all inclusive. So, hey, I put it on the syllabus. So what's going to be my introduction to lung ultrasound? Well, it's a little different. So when we talk about what makes the lung different and special is that it's not a solid organ. It's full of what? Air. And for those of you who watched my first couple of sections, I said, what is the enemy of ultrasound? It's two things. What are they? It's bone and it's air. So wait a minute, you're telling me I'm using the ultrasound in one of your biggest enemies, the lung? And I'm like, yeah, that's what we're doing. So it's a little different, you know what I mean? So the big thing is that, when we talk about interpreting how my lung is doing, it literally is a leap of faith. It is artifact driven. What do I mean by that? Well, up here, this is a solid organ, the heart. And you know what? You put the probe on the heart, it looks like the heart. You put the probe on the kidney, it kind of looks like a kidney. But when you put the probe on the lung, the enemy is air, so I had to use artifacts to describe the lung. So look at this down here. Yeah, that's lung. You see these little lines over here, like there's like an old black and white TV. Yeah, that's your lung. And so it's really hard when you show a patient, like, hey, look how your pleura is doing. You can't really see it because it's not there like a solid organ. But you know what? And all these things I'm pointing out are artifacts. We're going to be talking about A lines and B lines. I'm using artifact to describe an actual organ. And we've done that before because what did I put here is, this is what? An ECG, right? So, when this first happened, this is electrical activity of the heart. I mean, if I told you in the olden days that you see this P wave, that's the atrium. Look at that left ventricle. You would say, what are you talking about? But we've done it for so long, I see it. So that's where we are with lung ultrasound, is being used to all these different artifacts. And, as we use it more and more, it literally becomes a second language. So what are the indications for lung ultrasound? Well, I would say the most common thing is this chest x-ray right here. And I always say, to my fellows, describe what you see. And in this chest x-ray, I see a density where involving the right middle and right lower lobes. How do I know that? Well, I don't see the diaphragm, so the right lower lobe is involved, and I don't see the right atrial border. It's silhouetted off, so, the right middle lobe is involved. Then the question is, what is this density? Is it going to be consolidation or is it effusion? And so that's where thoracic ultrasound really takes place, and it's really helpful to tell me, what is this density? It is also super useful to help me determine if there is a pneumothorax, and we're going to spend a lot of time with that. And when I talk about, identifying a pneumothorax, I don't need radiology and a chest x-ray person to come in the room, especially, nowadays with COVID all the time, but in general, I can do it at the bedside after a procedure to see if something happened. And we'll talk more about that. If I do want to place a pleural tube or do a thoracentesis, it's also great to use the ultrasound machine. I can't even imagine not using the ultrasound doing a pleural procedure, and in some cases, this is kind of a reach, is it COPD? Is it CHF? This is another tool to help determine if it's one or the other. So scanning strategies. So I don't know if you folks, listen to my cardiac, lecture first, but, there are certain images that you see when you open the cardiac ultrasound book. You want to mimic these images there, so when you talk about the lung, this is going to be the classic image right here. And we call that the bat wing sign. Now, if you're thinking, hey, Dr. Raj, that doesn't even look anything like a bat wing, I agree. I'm not going to argue with you there. But what you want to do is you kind of want to get this image, with using your ultrasound probe in between the ribs. And you want to get this hyperechoic line, which is super, super white. You see these shadows on both sides. And this is going to be the classic view we're going to get when you want to talk about lung sliding. And we'll talk more and more about it. But this is going to be the classic view anytime we're talking about evaluating for a pneumothorax. can you get this view? And I'll tell you what to do once you get that view. It's called the bat wing. So, hey, I always like to repeat myself. So terminology is key. Ultrasound waves are formed by the transducer. We talked about that. Don't drop it. Don't drop the probe. It's made of piezoelectric crystals that cost a lot of money. And sound waves pass through various interfaces. And these interfaces could be solid, could be liquid. It depends. And depending on what the interface is, some can be reflected back. Some could actually get attenuated. We talked about all these different words. You know what I mean? And the sound waves that are reflected back to the probe, are detected as echoes. And those are the images that we see on the screen. I know we mentioned about this already, but it's good to kind of repeat myself. So when we talk about dealing with the ultrasound waves, the descriptive term is called their echogenicity. So when we talk about that, the definition of echogenicity is the ability to reflect ultrasound waves and produce echoes. And each tissue has a particular echogenicity in a normal state. So if I say it's very hyperechoic, it's white, like bone, like the pleura. Of course, now we're going to talk a lot about the pleura. If it's hypoechoic, one of the most common things, I said, think about lymph nodes, you know what I mean? If it's anechoic, it's going to be just black, you know what I mean? And all those, ultrasound waves are going to be what? Attenuated, And when we talk about a classic example of that is going to be kind of like a transudative effusion, CHF, cirrhotic, nephrotic, transudative effusions in the pleural space. So when you want to grab that probe, you know what I mean? Because we're talking mainly about, pneumothorax, you probably want to grab the linear high frequency probe. Once again, high frequency probe gives you awesome what? Resolution, but you're going to sacrifice the penetration. And that makes sense, right? Because if you're going to plop that probe right here to look for a pneumothorax, you really want to identify that pleura. The pleura is not huge, you know what I mean? You want to have good resolution to find it. And it's going to be a little more superficial, so you don't need deep penetration there. So I like using the linear probe, high frequency up here, you know what I mean? And that linear probe is probably what many of you use for what? Like, doing central lines, looking for that internal jugular vein. Sometimes people call the linear probe the vascular probe, just terminology. And there are different shapes of the probe. You know what I mean? I like the rectangle one personally. Then the other one, when we talk about pleural effusions, you probably want to use what's called a phased array. That's another word for a low frequency probe. And what did we say? It's good for depth, you know what I mean? But you lose some of the resolution. So when I'm looking for the pleural space, when I'm looking for the heart, when I'm looking at the abdomen, I'm looking forward to doing a paracentesis, I use a low frequency probe. And of course, they come in different shapes too. And many individuals use the pie-shaped. So I just threw out one of the most common shaped ones that people use in the medical ICU setting. And once again, why do I talk about protocol so much? I did mention this protocol in the cardiology section, is because you got to have a plan when you are using the ultrasound because someone is in shock. Where are you going to put the probe? What are you going to look for? What's the best way in a short period of time with limited views to figure out what's going on? So the blue protocol, is one that really helps me evaluate if a patient's going to have what? A pulmonary etiology for their shortness of breath. I mentioned already there are, three main points. There's blue point 1 called zone 1, blue point 2, zone 2, and the PLAPS point. PLAPS stands for posterior lateral alveolar pleural syndrome. Man, there's so many words. And there it is. I should have just switched the slide, And why is the probe down here? Because you want to look for pleural effusions, look for consolidations. And this is a nice, simple way with three main views to figure out, hey, does the patient have a pneumothorax? And could there be something else causing this patient to be short of breath? So here's the blue protocol. And now it's going to make a little more sense than when I first talked about it in cardiology, because now I can talk really about all these artifacts. And why is this important? What did I say separates, lung ultrasound from solid organ is artifacts. We need these artifacts to figure out what's going on in the lung when we talk about pathology or not. And the big thing is going to be looking for A lines and B lines. And we'll talk more and more about this. We're going to have pictures in my presentation coming up, so we'll dive into it. But this is one of the many protocols that was used and validated to help figure out why is the patient short of breath. And it really starts off with ruling out pneumothorax. And we could do that by looking at lung sliding. If you have lung sliding, thumbs up, you don't have a pneumothorax. It's the lack of that really makes you worrisome. And based upon that, we're going to use these artifacts such as A lines and B lines to figure out, hey, if you have bilateral B lines, well, I mentioned it could be like a pulmonary edema. A lines are so tricky because you could have A lines, well, you naturally have A lines, and you could have it with a pneumothorax or without. So it's really not going to be a deal breaker over there, and we'll talk more about those, and we'll talk about terminology. If you don't have sliding lung, probably the most accurate image you want to find is called lung point to really say as close to 100% as possible, is there a pneumothorax or not? And we'll talk about it. And of course, in this conversation, meaning this lecture, we'll also talk about, pulmonary embolism. And truth be told, I'll say it 1,000 times, you cannot diagnose a pulmonary embolism based upon an echo. There are findings that may suggest it could be a PE, but one thing you can do is rule out a deep vein thrombosis in your legs. And it's not as tricky as you think it is. So that's why when someone's short of breath, if you diagnose a DVT in the acute setting and they say, hey, I have pleuritic chest pain, maybe they have a PE. In the acute setting, it pretty much wouldn't change your management that much in the acute setting. And that PLAPS point is going to come down here to say, hey, is there some effusion or consolidation in that zone 3, which is going to be lateral and posterior in the patient. So this blue protocol provides, according to this study, almost a 90% accuracy in helping you in the ballpark area of the diagnosis. But of course, it should be done as part of the physical exam and other investigations. Use the chest x-ray, use the labs, put them all together with this to help make the correct diagnosis.